Hi, this is Dr. Kaucher. I will be presenting your health promotion and common health problems in women. This is chapter 3 and 4 in your textbook. This is our jumping off place for helping women across their lifespan. Just a little pre-lecture blurb. I need you to let your PowerPoints be your guide to help you in study. Write notes on them from the lecture recordings and from your textbooks. This is slated to be a 3-hour lecture. I will strive to keep the recording down to 2 hours or less. The remainder time is for activities associated with this lecture. So please refer to your course guide. This is a welcome to your first introductory lecture. Chapter 3 will begin with a brief overview of the female reproductive system. I'll not be going over in depth and detail this information, but do know that it is testable material. Don't worry, I will send a test plan out that will let you know the areas of study that you should focus on. If I have anything that has to do with the female reproductive system, then I'll let you know to make sure you focus on that. But if you need a brush up and kind of a reorient yourself to everything women related, then I would suggest that you look at that. Lecture materials are presented in YouTube video and voiceover recordings. And again, make sure that you take notes from these. So the female reproductive system, you have your internal structures, your external structures, the bony pelvis and the breast. External structures all are the structures visible externally from the pubis to the perineum. This includes the mons pubis, labia majora, labia minora, the clitoris, the vestibular glands, the vaginal vestibule, vaginal orifice, and the urethral opening. Internal structures include the vagina, uterus and uterine tubes, the fallopian tubes, and ovaries. There are 3 primary purposes for the bony pelvis. You need to know that they're for protection, accommodation, and they are an anchor. The breasts, they function in the form of lactation and sexual arousal. Again, I'm not going to go into depth, but you may need to refresh yourself. With the female reproductive system, you need to look at your menstrual cycle. That would include the endometrial, hypothalamic pituitary cycle, the ovarian cycle, and any other cyclic changes. Look at the prostaglandins. I will say that the climacteric phase of a woman's life, that this kind of goes hand in hand with menopause, so I'm going to kind of touch on this for just a second. This is a start phase in which the ovarian function and hormone production, they start to kind of take a decrease. They start a gradual decline. It's pretty much referred to as the premenopause phase. Now, this can start happening, maybe 10 years before menopause comes on, and then as a woman starts to hit menopause, you'll get perimenopause, and we'll talk about that in another slide. But just know that is one of those that's one of those words that you might see again at some point in time, and so you might want to know what it is that goes along with the menopause and how we would want to care for a woman during that time. So what are the reasons that our women enter the healthcare system? They might need some preconception counseling, health promotion, such as just general teachings and anything from their overall health, having starting birth control, starting a family, all of those things. So some do not even seek care. You might find a lot of women that do not actually go to find care until they find out that they are pregnant. Others may start seeking care when they want to start that family. Then others may do it because they're looking for contraception. And that may be the first time that a woman actually enters into a women's health care facility. Or there may be infertility reasons. Preconception counseling, some things that we want to talk about when we're looking at preconception counseling is we want to emphasize nutrition and prenatal vitamins. when addressing the pregnant patient. We don't want them to smoke and drink alcohol. If they're seeking our guidance for preconception counseling, we need to let them know that if they're looking to get pregnant, then stopping smoking and not drinking are two things that really they need to focus on. Because if you are trying to get pregnant at a time when you could be pregnant right then and drinking alcohol and not know it, so you're potentially exposing your embryo to harmful substances. We need to look for any indications for genetic testing. Is there a history of genetic problems within the immediate family or on either side? Now, when pregnancy is found and they come into the healthcare facility, then we want to know that we're getting their prenatal care started within the first 12 weeks. This allows us to take initiation of measures to prevent any problems or to start treatment. And remember what I said about alcohol and smoking. Organogenesis is complete within the first 8 weeks of the fetus embryo's life. So that's why it's an important thing for us to let women know during that preconception counseling that any harmful substances that they're putting into their baby or into their body, their baby could potentially be exposed to it. So, we need to identify any risk. Do they have any pre-existing health conditions? What was their previous pregnancy history? Do they have a family history of pregnancy problems? So all of these things that we're looking at as the woman first enters the healthcare system. We also look at well women care. This includes a woman's healthcare needs throughout her lifetime. Again, her initial entry may be for contraception or a pap test. The needs of all women do vary by age. It varies by culture. It varies by religion and socioeconomic status. Menstrual problems also may bring a woman into the healthcare clinic. They may be disturbed by some of the problems that they're having, pain before, during intercourse, pain after intercourse. What if they are experiencing bleeding between menstrual cycles? We'll talk about all of those different types of bleeding later on, but this is just discussing why they may come into this facility. Fertility control is another issue that might bring them there. More than half of all pregnancies in the United States are unintentional. Education is the key to encouraging women to make family planning choices. We as providers, we as nurses, we as doctors, we can influence the user's motivation and ability to use a method of contraception. We want them trying to use something. If they're not wanting to be pregnant, we need them to do something. We don't want it to be an unwanted pregnancy because what if the woman is not financially able to take care of that pregnancy? There's nothing that says that she'll put the infant up for adoption. She may try to take care of that infant, and it's just going to cause a bigger hardship. A woman may not necessarily be upset. And remember when I talked about you about the climacteric phase, the premenopause phase. When the woman might start coming in for that is during the time of perimenopause, because that's when they start getting those hot flashes and waking up in the middle of the night and they're struggling because they're drenched in sweat from the head down to their waist, and that might be what drives them to the clinic. It's very uncomfortable, those symptoms. Cessation of periods doesn't really bother women, but the symptoms that go along with it actually do. Now we're going to talk about some health disparities. To me, I look at some of this data, and I looked at some of the data in your textbook, and to me, it's really staggering. In a day and age that technology is advancing and education of the population has increased, I just feel like we should not be seeing this as we do right now. There is so much racial and ethnic diversity that's increasing in the U.S. By 2060, there's an estimated 43% of the population will be composed of non-Hispanic whites. Um, Different race and ethnic groups experience significant, and that's why it's important for us to know that, significant disparities in morbidity and mortality. They have a shorter life expectancy, higher infant and maternal mortality rates, more birth defects, and STIs. There's a really complex interaction between biologic factors, environment, and socioeconomic factors, and the health behaviors of this population. And I will tell you, I remember being in nursing school, and I'll try to keep my story short, but some things are they just come out in lecture because it just brings it to life. I was working at the Sheridan Health Clinic, and we had this young lady come in, and she had all of these sores in her mouth, and got to questioning her, and come to find out she was still a virgin. However, she had a boyfriend who told her that if she wasn't going to have sex with him, that she needed to at least, take care of him. And I know y'all all know what I mean there. But listen, guys, the mouth sores that she had, it was a sexually transmitted infection, and she was trying to do what her parents wanted, and remain virtuous, and not have sex, but she ended up with an STI that was in her mouth. So it was quite disturbing to me and the other nursing students there, and it's pretty disturbing to the nurse, because I believe she was, if I remember correctly, 12 years old. It was just too young, way too young. There are many barriers to seeking health care. There can be financial issues. Limited money usually means limited access to care. There are very few preventative services that are actually sought. There's a link between a job and health insurance in the past, but now we have the healthcare marketplace, and that's thanks to the Patient Protection and Affordable Care Act. I know a lot of us, call it Obamacare. You hear it called Obamacare on TV and everywhere else. This means that lower income individuals have a better shot at receiving medical care for their illnesses. Many coverages, though, are very inadequate, and some don't even cover maternity care. Even Obamacare policies offered have some limitations, and they have a lot of high deductibles that have to be met. Many choose this insurance option because they've opted out of receiving. They don't want to receive penalties on federal tax returns. Some people, though, won't do it because, they're just going to take the penalty. The penalty is not that bad. And now we have a new administration, so there's even bigger health care challenges and changes that are probably going to be coming. Women make up the majority of our Medicaid recipients. Single, separated, or divorced individuals are less likely to have insurance. Unmarried teens are usually covered by parents, but a lot of insurance plans now will not cover maternity services. We also have cultural issues. Our nation is becoming more and more diverse. There is fear of racial discrimination that may be a reason that some women don't seek health care. Language barriers also can produce some profound difficulties. We need to make sure that we're exemplifying cultural competence. We need to show our respect to women. We need to show our respect to their religious practices, their cultural practices. You need to make sure that you're being aware of the diversities that exist. This goes a long way in communicating effectively and therapeutically. And let me tell you, when you don't agree with a patient, and I think we probably have all seen it at some point in time, when what they're saying just doesn't jive with us and we think that is the most ridiculous thing that I've ever heard, you need to make sure that you put a filter on your face. We have learned how to filter our mouths, but we have not learned to filter our facial expressions. And that is just not being communicating effectively with our patients. we can't treat all people the same. What if a woman doesn't remove undergarments and we need to do a pelvic exam on her? You need to think about how would we go about handling this. Ask her, tell me about these. Can you explain why you don't want to remove them, why you're actually wearing them? Listen to her attentively. Please watch the filter on your face. And then we have to do our teaching. We have to explain to her why we're actually doing this, that we need to have undergarments removed. You can come up with a resolution together. You can still honor her religious convictions, but also we need to make sure that we give the healthcare team a chance to treat her appropriately. We also have gender issues now, sexual orientation. Gender believe it or not, of the provider can play a role in a woman seeking care. A lot of women won't go to a male doctor. It just makes them uncomfortable. They only want to go to a female. They might not be able to get it with the female doctors because many women seek the female physician to treat them. Studies have shown that women have yearly exams and mammograms more consistently if they're seen by female providers. Lesbians may feel hostility or feel they're not at risk for certain diseases or cancers, but that's not true. They still are. If they have no children, then they have a higher risk of breast, ovarian, and endometrial cancer. And they're still at risk of HIV and STDs. Adolescents. The development of secondary sex characteristics is a big time of change and stress. If you've ever had an adolescent female, then you understand that. They undergo many developmental tasks, such as establishing their identity, breaking away from the family. Thinking processes do not usually include planning for the future. Pap screen is usually a pivotal exam for adolescent girls as they develop perceptions that may hinder or encourage these routine exams. Teenage pregnancy. A sexually active teen who does not use contraception has a 90% chance of pregnancy within 1 year. It's a lot. Many teens do not seek prenatal care until the second or third trimester due to lack of realization that they are pregnant or that they are in denial. They may be unsure of where to go or how to seek out the care, and they also want to try to hide that pregnancy for as long as possible. Teens usually do not adhere to healthy prenatal behaviors, especially appropriate nutrition and continuing care. Children of teen mothers are at risk for abuse or neglect because of the teens' inadequate knowledge of growth and development and parenting, and guess what? They're still growing and developing. There's been a decline, which is good, of 31% in teenage pregnancy since 1991, and that's due to a lot of specialized programs in schools, but there's still 77% of teen pregnancies that are unplanned. Teenagers are just some of the most impulsive individuals out there, and they place a lot. They're notoriously selfish as well. They place a lot of importance on what peers think, so consequently they may not realize what impact their behaviors is having on others. That can be their newborn child, their unborn child, or their parents or siblings. They don't understand the financial resources to care for themselves, and they certainly don't know the financial resources for caring for a child. So it does add a lot more stress on the family unit. So health risk in the childbearing years, we're looking at age. By age, ages 20 to 40, women may use their OBGYN as their primary care doctor. Because they're going to her or him for contraceptive needs, pregnancy needs, or menstrual problems. It can be some stress-filled years, though, of juggling family, home, career, and causing multiple stress-related illnesses. Promotion of a healthy lifestyle is important. So we want to encourage these women during this time that we're counseling with them to have a good nutrition, good exercise, don't smoke, get sufficient rest. And we probably need to be addressing their mental health care needs. Mental health care needs have kind of come to the forefront here lately, which is really good. So we need to be looking at that. Are they depressed? Are they spending I'm not going into our mental health, but you understand what I'm saying. I don't want to cross the two there. Parenthood after 35, they have age-related changes in their health status. For example, they might become a type 2 diabetic, and so they have, with the type 2 diabetes and their conception, not contraception or conception, but if they're having a pregnancy, let's just say that, we have a type 2 diabetic, or we have a woman who has hypertension. These add a little bit extra to the pregnancy. She's going to be a little bit more high risk, actually a lot more high risk. Those are also going to increase her financial needs, because not only is she going to be seeing her doctor, her OBGYN, but she's probably going to have to see a high-risk OBGYN. They also are at high risk of infants with Down syndrome if they conceive during this time. Late reproductive age, women are undergoing a reordering of personal priorities at this age. Divorce rates are high, and empty nest syndrome sometimes leads to depression. And if you have a woman who is of late reproductive age, who is in perimenopause, she can still get pregnant, and it does happen. So some of the health risk in childbearing years, substance abuse, smoking, tobacco use is a leading cause of preventable death and illness. It is linked to cardiovascular disease, cancers, chronic lung disease, and negative pregnancy outcomes. It will cause a decrease in placental perfusion, and so consequently you have low birth weight babies. The average cigarette smoker shortens his or her life by about 6 to 8 years. Smoking impairs fertility in men and women. Alcohol, a third of alcoholics are women. Abuse during pregnancy is a leading cause of mental retardation in the U.S. Sorry, I didn't mean to hit my mic. Prescription meds. I have to stop here because we do have a what we call an opioid crisis in the U.S. Misuse of prescription meds, sleeping pills, stimulants, pain relievers, those all can cause some psychological and physical dependency. And you have about an estimated 2.3% of American women who regularly use these items. Depression is the most common mental health problem in women. Many kinds of meds are used to treat depression. All can have some type of effect on the fetus and must be carefully monitored. This is why we really want our women to get some preconception counseling. I think we're making great strides in healthcare to take the stigma away from people seeking healthcare for their mental health care needs. Excuse me. But for our women who are planning to become pregnant, we also need to make sure that we're checking what pregnancy category does this drug fall in. Then we have illicit drug use, and you have cocaine users. A lot of them let me back that up. Okay, so with illicit drug use and cocaine use, you will find that more people that use cocaine actually are HIV positive or have switched on over to AIDS. Now, there is a legal alert that I will tell you right here. No requirement for healthcare professionals to test pregnant moms or newborns for drugs. In some states, a positive urine drug screen during labor and delivery requires referral to Child Protective Services, and it is unlawful to test for drugs without a pregnant woman's consent. I tell you that to be aware that as you are following labor and delivery women and postpartum women, you may suspect that there is some drug use, but we have policies at Baptist. I don't know what those policies are at this point in time anymore, but wherever you work, if if you're working labor and delivery, postpartum, NICU, pediatrics, you'll need to find out what those policies are, and be aware that even if it's reportable, that likely, unless it's just bold in your face, that baby is not going to be taken from that mama. All right, so nutritional deficiencies. Good nutrition is really essential for good health and helps prevent illnesses. Lack of folic acid, you're going to get babies who have neural tube defects. For older women, lack of calcium in their younger years will lead to osteoporosis. What if they eat a lot of sodium? There's always a risk of hypertension, fad diets, yo-yo diets, dieting, so you have some imbalances there. So, in our country, it's kind of, we're probably one of the most overweight countries. So some of the things the imbalances that we look at are the overweight or underweight. Do they have a malabsorptive issue? Are they fatigued? Do they have frequent colds? Are you noticing that the mom has dull hair and nails, and they have dental caries? That poor nutrition, especially if it's related to obesity and high fat and cholesterol intake, can lead to some really serious problems. It contributes to 4 of 10 leading causes of death in the U.S. From cardiovascular disease, neoplasms, cerebrovascular disease, and diabetes. Obesity in the past 20 years there's been such a dramatic rise in the U.S. There's risk to, and I mean, I don't know if anyone else has noticed, but I can remember, and I'm almost 50 years old, I can remember seeing kids back when my kids were younger, and you didn't see overweight kids. And now I see so many overweight children out there, and by no means are mine perfect. Don't think that that's what I'm saying, but I think that I think there's a problem. I think we've got a really big problem. There are absolutely so many kids out there who have excessive amounts of weight on them. So the risk for women who are obese is they're going to have high cholesterol. They're going to end up with menstrual irregularities, hirsutism, stress incontinence, and depression. Risk during pregnancy, you're looking at hypertension, diabetes, gallbladder disease, and then there's post-term. They might have some musculoskeletal problems. 30% of women are obese. Highest prevalence is between ages of 40 to 59. Obesity has some really far-reaching effects. And I don't know if y'all realize this, but Americans are being diagnosed younger and younger with type 2 diabetes, and this carries over to a pregnancy and making it more challenging to care for these high-risk OB patients. So a couple of risk, eating disorder risk, anorexia and bulimia. They are psychological disorders. Anorexia commonly begins during adolescence. It results in a metabolic and endocrine abnormalities, arrhythmias, amenorrhea, cardiomyopathy, CHF, and death. If not corrected, then the patient has some significant complications such as arrhythmias, amenorrhea, cardiomyopathy, and CHF that can occur, and in extreme cases can lead to death. I always think of the singer Karen Carpenter. Probably a little beyond y'all's time, but you hear a lot of her Christmas songs on. And she died from complications with anorexia. Bulimia is more secretive. They'll have secret, uncontrolled binge eating that alternates with different methods to prevent weight gain, such as self-induced vomiting. They could even take laxatives, and not just one or two. Occasionally, I'm talking multiple amounts of and massive amounts of laxatives. This usually begins in early adulthood, 18 to 25. Complications include dehydration, electrolyte imbalances, GI abnormalities, and arrhythmias. More likely that they're going to feel shame or disgust about the bulimia and seek help earlier. The treatment plan, though, for eating disorders initially focuses on reestablishing physiologic homeostasis. Uh, you can work on a patient's diet plan all you want to, but and you can even work on their psychological being all you want to, but if we are not working on restoring their physiological status, then we're doing for naught. Just because by the time that they're seeking help or are getting help, then likely they have some serious issues going on with their physiological body. You can make a diet plan, but if the system is out of kilter, it's not going to work. So homeostasis physiologically has to be the priority. The goal, though, would be to identify our at-risk women before some serious physical problems actually start to arise. And part of that is using that screening disorder that I have on your screen right now. These are the SCOFF questions, and you can see I've outlined the do you make yourself sick, and it's underlined the S right there, such as induced vomiting because you feel too full. Do you worry about loss of control over the amount you eat? Have you recently lost, and obviously this comes from a British person, 1 stone, so 6.4 kilograms or 14 pounds in a 3-month period? Do you think you are too fat even if others think you are too thin? Does food dominate your life? Each of these questions scores at 1 point, and a score of 2 or more indicates that the person may have an eating disorder. Physical fitness and exercise. We want our young women, older women, all across the lifespan to include in their lifestyle a 20 to 30 minute of moderate activity at least 3 times a week. Physical inactivity does increase with age, maybe some age-related problems like sore, and aching joints and muscles. We also want to talk to them about Kegel exercises, because a lot of times what you're seeing is some older women may not want to exercise because of they have urinary leakage. And I always thought that everybody knew what Kegel exercises were until last year. And I had my stepmother who was telling me she was having urgency urinary leakage, and I thought maybe I asked her lower back hurt. I think it might have been psychosomatic, because everything that I listed, does this or bother you? It all bothered her. But come to find out, she actually had no UTI. This was just because she had weakened pelvic floor muscles, and also she had had a hysterectomy years before. And I just assumed, and that was bad because I'm a nurse and I'm a GYN nurse, and I should have known to talk to her about Kegel exercises, but I'm ashamed to say I didn't. So women can also benefit from doing some physical therapy if they're having some loss of urine, and it's become quite disturbing. I know physical exercise, but it really does work. Go to a physical therapist, and I don't know all of the ins and outs with it, but there are those physical therapists that focus on that for men and women, actually, to prevent urinary leakage, especially men who've had prostate problems. But women can also buy something called Kegel balls, and these you can buy them even off Amazon. They were developed by a physical therapist, and a woman will hold these in for 20 minutes a day, and it gradually increased the weight of those Kegel balls, and it helps to strengthen the pelvic floor muscles so that she doesn't have urgency and urinary leakage. So these are things we need to be making sure that we teach our women about weight control and about exercising. We want to talk to them about, especially about urinary leakage. It's embarrassing, and so a lot of women don't want to discuss it. But these are things that we need to be teaching them about, doing the Kegel exercises or buying the Kegel balls if that helps them. There's also benefits of exercise during pregnancy. It's weight control. It's also protective against gestational hypertension and diabetes. Okay, so stress can have some problems and cause some problems on our physical as well as psychological selves. Stress, women are just prone to stress-related complaints. We carry multiple roles that we have to fill. Some stress is normal. Excessive stress can lead to physical problems. We have to learn how to manage stress. Sometimes that's counseling, support groups, coping skills, relaxation techniques. There are some physiological problems that go along with the stress. High blood pressure, increased heart rate, decreased digestion. Then there's a massive release of neurotransmitters and hormones. We get muscle tension, and then we have a weakened immune system. Of course, there's psychological symptoms that go along with that as well. Anxiety, irritability, eating disorders, depression, insomnia, and substance abuse. Constant stress can result in exacerbation of arthritis and asthma, frequent colds and infection, GI upset, cardiovascular problems, and infertility. We also need to be able to evaluate our patient's sexual practices. It can result in undesired pregnancy and STDs, STIs. Education to prevent STDs and Is are an undesired pregnancy are very we listen we when we're talking to our young women, we need to be doing this. This is something that needs to be happening on a regular basis when we're doing our intake assessments with them. It's such a higher risk in adolescents have not a lack of knowledge about contraception, or they just think they're invincible and it's not ever going to happen to them. They have lack of knowledge about transmission of STDs. They may become sexually active due to peer pressure, enhance their self-esteem or their desire to be loved, or they may just be looking at experimentation. We need to be assessing medical conditions and gynecological conditions when we're talking to our young women. Are they having painful periods? We need to be making these assessments. Are you regular? Talk to me about your periods. And it's sometimes, again, I don't know why, but women's health is sometimes a little bit hard for nurses to address. We typically breeze past it. We don't want to talk about their sexual health. We don't want to talk about their gynecological problems. We don't want to talk about urine leakage, but we need to be talking about these things with women. We need to be looking at environmental hazards and workplace hazards. These can affect fertility, fetal development. It can affect the live birth and the child's future mental and physical development. Children are at a special risk for poisoning from lead. And everyone is at risk of from air pollutants such as tobacco, carbon monoxide, smog, suspended particles, and cleaning solvents. There are the green cleaning products that are natural. We tend to use these in the hospitals, and they're used a lot on the East Coast. I know for myself, I have started using, and listen, I'm all about the bleach as well, but as y'all all probably learned during our orientation, I full time in my RV, so they recommend not using harsh chemicals on some of the surfaces in there and on the plumbing. So I've gotten into using baking soda and vinegar. It works really great. There's beautiful shine, and so some of if we have people that are particularly prone to asthma or particularly prone to these things bothering them, we want to look at some of the natural things that we can encourage them to use. All right, so health promotion and prevention. So we've talked about everything that they're at risk for. Now let's talk about the things that they're actually doing and what we can do to help them to stop. We want them to stop substance abuse. We want to ask them about their smoking history. We want to ask them about their desire or attempts to quit. assess their barriers to quitting, their support system, advise them. We want to educate them on the effects on their health. We want to provide them with support. We want to help them set a quit date and refer to smoking cessation programs, stress reduction activities, arrange a follow-up. We want to congratulate success, and we want to provide support for relapse. Nurses have a major opportunity and responsibility to help women understand these risk factors, and we want to be able to motivate them to adopt healthy lifestyles that prevent the disease. Lifestyle factors that can affect health and that the women do have some control over would be their diet, tobacco, alcohol and substance abuse, exercise, sunlight exposure, stress management, and any inappropriate sexual practices. Are they making sure that they're using condoms, or that they are protecting themselves adequately? Why men are not allowed to take messages. Someone from the gynecologists called. They said the Pabst beer is normal. I didn't even know you liked beer. I love this one. All right, so anticipatory guidance. We're still looking at health promotion and prevention. For Pap tests, there's new research that says every 2 to 3 years is good if they've had a negative test. So we want them to initially have one 3 years after they become sexually active, or by the age of 21. Ages 21 to 65, they recommend it every 3 years. I say that with a little sarcastic tone. Sorry about that, because I haven't met one gynecologist yet that does it every 3 years. I've had a hysterectomy, and I still go in for cervical check every 3 years. My daughters still, or every year rather, not every 3. I was looking on the computer. My daughters still have their Pap test every year. Age 30 to 65, every 5 years, if they, HPV, 65 and 3 negative tests or total hysterectomy, they might not do it at all. They'll just do a pelvic exam annually until the age of 70. Patient, patient teaching to prevent false negative or false positive results. Avoid douching, sex, or using vaginal meds or hygiene products for 2 days before the test. Not recommended if during your menstrual period. With the pelvic exam, an exam of the vagina, cervix, uterus, fallopian tubes, ovaries, and rectums is what usually is done. With the vaginal self-exam, we need to do vaginal self-exams. Take a mirror and a flashlight to look for any abnormalities. Okay, so we want our women to get clinical breast exams at the ages of 20 to 39 every 3 years. Over the age of 40, then we start doing annually. We need to encourage self-breast exams monthly, 1 week after their period. We want mammograms to start every 1 to 2 years after the age of 40, annually after the age of 50. Now, there is some new data out there that the older you get, the less you have to do this. You can do MRIs in women with high risk of breast cancer. We also look if they're carrying the BRCA1 or BRCA2 genes. We also look at family history. Is there a first degree relative, such as a mother, daughter, or sister with breast cancer? We want to teach when having a mammogram done to schedule 1 week after a period when the breasts are less sensitive. We want to avoid deodorant, powder, or perfumes because it can appear similar to calcification on the mammogram screening. MRIs do find breast cancer more often than mammograms do, but it is common for an MRI result to appear abnormal even when there isn't any cancer. The risk of breast cancer screening tests include the following, false negative results, because when you get a false negative, if anybody's ever had one, you understand that there's a fear that you get when it comes in the mail and you get that. False positive results are not the false negative. The false positives can give you that heart-sinking feeling. You get a little anxiety for it. If you get the false negative, then you're told that you're clean, but you're really not. Mammograms do expose the breast to radiation, and there may be some pain or discomfort with the mammogram itself. Yes, I did have my mammogram today. Why exactly, do you ask? So this is the breast self-examination chart that we need to be making sure that we are talking to our young women about, and older women. Not everybody knows how to do a breast self-exam, just like they don't all know how to do Kegel exercises. Changes to report if they have a lump or a thickness or firm tissue in the breast or under the arm. Change in size or shape of the breast. Nipple discharge, nipple changes if they suddenly are inverted or retracted. Skin changes such as itching, redness, scaling, dimples, or puckering. So what do we need to get? What do we need to do when we see these women? We need to make sure we get a blood pressure, height, and weight on them every visit, or at least every 2 years. We want to encourage getting their cholesterol checked every 5 years. Colon cancer screening is done. We want to check fecal occult blood annually. Sigmoidoscopy is every 5 years after the age of 50. A colonoscopy is every 10 years after the age of 50. We want to also look at fasting blood sugars, family history. Do they have a history of diabetes, gestational diabetes, or are they obese? This needs to be checked annually. And now, let me just say that for diabetes, there is a greater clinical or genetic component to it, to type 2 than there is type 1. Type 1 is an autoimmune. A lot of people misunderstand that. But type 1 is autoimmune. Type 2, that's going to be passed on. Mom, dad, if your mom and dad both have it, then there's a good chance that you're going to have it. We want to assess, I mean, in this day and time, it's kind of crazy to think about wearing seatbelts. Most all cars, unless they're driving an older one, there's seatbelts have to be worn. If not, the little noise is going to ding at you forever. You can also get a ticket for that. However, we want to ask, are they wearing their seatbelt? Maybe they're one of those that they buckle it up behind them and they think they're invincible and don't have to wear it. Do they wear a helmet when they're riding a bike and on a motorcycle? Are there working smoke alarms at the home and at work? We want to find out if they're being exposed to secondhand smoke, because we want to encourage them to try to prevent that. Prevent the skin from being tortured by UV light. And I say that kind of, I don't think it's torture, but that's me. I'd have been a sun worshiper years ago. But I'm being silly. Just haven't thrown a little funny in there. But no, seriously, making sure our women are they using UV protection, especially are they doing so on their face? Or, our face is going to be exposed to it every day when we walk out. So are they using a moisturizer or some type of cream that's going to protect their face? So now we're getting ready to talk about common menstrual disorders. And I'm just listing them right here. We're going to go through those one by one. Amenorrhea, dysmenorrhea, premenstrual syndromes, endometriosis, oligomenorrhea and hypomenorrhea, menorrhagia, and abnormal uterine bleeding. Amenorrhea is the absence of menstrual flow. It should be evaluated if the absence of both menarche, and that's the first time that they start a period, and secondary characteristics are not present by the age of 14. If they have absence of menses by age 16, regardless of normal growth and development, and a 3 to 6 month cessation of menses after a period of menstruation. 98% of American girls menstruate by the age of 16. A thorough history and physical exam is needed to determine the cause. Initial step is to rule out pregnancy. Strenuous exercise, anatomic abnormalities, type 1 diabetes, and a hysterectomy are all causes of amenorrhea. Um, the absence of menstrual flow, there are two. There's a primary and a secondary. Primary would be absence of menses by the age of 16, and that's regardless of the normal growth and development. Secondary is when they are 3 to 6 months cessation of menses after they've been menstruating. The most common cause would be pregnancy, but if not pregnancy, we have to find out what's going on, do those good health assessments, ask those good questions, what their history is, their eating, their exercise, all of these different types of things that we just talked about, we need to be assessing for these women. So, hypogonadotropic amenorrhea, this is a problem that occurs in the central hypothalamic pituitary axis. It's possible inability to produce FSH and LH. This could be related to a pituitary tumor, Cushing's disease, an adrenal tumor, hyper or hypothyroidism. Get hypothalamic suppression, and this could occur because of stress, sudden weight loss greater than 20% that are underweight, eating disorders such as anorexia, or strenuous exercises. This may be a genetic inability to produce follicle stimulating hormone, the FSH, or the luteinizing hormone. It could be related to congenital abnormalities or reduced function of the ovaries. Could also be a result of oral contraceptives, meds such as Dilantin, or illicit drugs. Strenuous exercises such as dance, gymnastics, low body weight, running, swimming, and figure skating can also bring it on. So we have to be very, very good diagnosticians and look and see what's going on. So what we have to do is, first of all, diagnose. We need to look at doing a pregnancy test. If that's negative, we're looking at thyroid studies, FSH and LH, looking at those prolactin levels. We're going to probably find that these women are experiencing hypothermia, decreased blood pressure and heart rates, and decreased amounts of subcutaneous fat. Um, You're going to have facial hair and acne if they have a tumor. So that occurs with the excessive amounts of androgen in their system. Absence of axillary or pubic hair, and that can be because of the adrenal or ovarian hyposecretion and delayed puberty. Most causes, though, are reversible. Management, treat the cause. If need be, we start them on estrogens, progesterone, or oral contraceptive pills. If it's a pituitary tumor, we're looking at meds, radiation, and surgery to get rid of this and get this out of the body. Hypothalamus failure, we are going to look at starting this woman on gonadotropin and releasing hormones. Counseling and education. We want to make sure that we do this, and we want to talk to them about their nutrition, and we want to talk to them about their stress, because it could be related to the anorexia. So we really want to make sure that we're following up and doing the appropriate amount of counseling with them over the right information. You don't want these eggs made for you? Fine. You know what? That's just great. These are perfectly good eggs. I spent all month slaving over them. It's fine. I'll just throw them away. Whatever. No big deal. There's an angry uterus and ovaries. Dysmenorrhea. This is pain during or shortly before menstruation. It is more common in women ages 17 to 24. Also more common in women who smoke or are obese. Pain is located in the suprapubic area or lower abdomen. You're going to experience some sharp cramping or a steady dull ache. It may radiate to the lower back or upper thighs. About 30 to 40% of women report some level of discomfort during menstruation. With a lot of women, it does improve with age or after a full-term pregnancy. It can range in severity of symptoms and vary from woman to woman and from cycle to cycle. It's also categorized as primary or secondary. With primary dysmenorrhea, pain begins at onset of menses and lasts 8 to 48 hours. There is an absolute physiological alteration in them because the increased prostaglandin release causes the myometrium to contract. It's most common in late teens and early 20s with primary dysmenorrhea, and the incidence does decrease with age. So when that myometrium contracts, they get vasospasm of the uterine arterioles and ischemia. It can be very, very painful. Levels are high at the beginning of the period as the lining of the uterus is shed. Levels decrease and pain then starts to decrease. Treatment aimed at increasing vasodilation and muscle relaxation and minimize the uterine ischemia. Decreasing salt and refined sugar intake about 7 to 10 days before the expected menses may kind of help reduce with some of that fluid retention. Increasing the water intake may serve as a natural diuretic, or they could eat some natural diuretics such as asparagus, drink cranberry juice, or eat peaches and watermelon. We would probably encourage some NSAIDs for these patients. It does act as a prostaglandin inhibitor. Oral contraceptives can also be prescribed for these women who do not wish to become pregnant. It will diminish the production of the prostaglandins. There's other things that we can do, such as insert an IUD, a heating pad on the abdomen, or those little hot packs. I wish that those little things had been around when I was having periods. You know, the ones that you can get now that you just put them on to whatever part of your body that's hurting, and they heat up and they'll last for like 8 hours. I mean, those are great. Put one to the back and one to the abdomen. Secondary dysmenorrhea is associated with the pelvic pathology, such as endometriosis, adenomyosis, fibroids, pelvic inflammatory disease, or endometrial polyps. Adenomyosis is a tissue that normally lines the uterus that begins to grow in the muscle wall of the uterus. So these conditions can cause quite a bit of pain. Diagnosis, we're going to do a pelvic exam. We're going to do an ultrasound, endometrial biopsy. We might even do a laparoscopic exam to see what's going on if all of these others are not as conclusive as what we need. Management is going to be directed at removing the underlying pathology. So if woman is not wanting to become pregnant or has had all the babies she plans to have, either way, then we're going to look at probably taking that uterus out and relieving her of these symptoms. PMS. This is a cyclic, physical, psychological, and behavioral problem. The symptoms occur during the luteal phase of the menstrual cycle. That means it starts to occur between ovulation and the onset of menses. 85% of women experience symptoms with PMS. 40% of women report some disruption of their daily activities. Ovarian function is necessary, though, for it to occur. So once the ovaries are out, then they're not going to have this any longer. It must occur regularly prior to menstruation to be considered PMS. There are no diagnostic tests to determine the existence of PMS. The healthcare provider must confirm a pattern of symptoms. Is it present in the 5 days before the period for at least 3 consecutive cycles? Does it end within 4 days after the period begins? And does it interfere with normal activities? We want to recommend that patients keep a record of symptoms, including the dates, for 2 to 3 months. Conditions that mimic PMS, depression, and perimenopause. PMS can make other conditions worse, like seizure disorder, migraines, asthma, and allergy. allergies. If you've never experienced PMS, then you probably are not very symptomatic to it. But if you have experienced it, then you know that the anxiety, the cravings, the depression, the hydration, I mean, it's all kind of, I mean, it's all miserable. With the hydration, you get extreme. It's not just like a little bit of weight gain. It's quite a bit of bloating and extreme breast tenderness. Women have breast tenderness in the first place when they're menstruating, but with PMS, these symptoms are really enhanced. It's like the period on crack. The management, aerobic exercise, diet modification, limit sugars, and that's really hard. Salt and caffeine, red meat and alcohol. Relaxation strategies such as yoga, meditation, massage, and good sleep. Diet modification, we want to increase the complex carbs that we're putting into the body. Look at whole grains, pasta, rice, and beans. And I like the protein pasta. It's a really good complex carb. Magnesium supplements will help reduce the water retention, breast tenderness, and mood symptoms. Natural diuretics such as, and I said these earlier, peaches, watermelon, asparagus, and cranberry juice. Now there is a variant to this, and let me address that in just a second. I forgot to tell y'all that you can oral contraceptives and NSAIDs are what's recommended for these women who are experiencing PMS. Um, NSAIDs, you usually want to start those about 7 to 10 days before the onset of the period, because it will get into the system and start to build and help quite a bit. Uh, they might need some Paxil, some Celexa, some Prozac, some Zoloft, any of those things, because of the depressive, anxiety-ridden feelings that come along with it. PMDD is premenstrual dysphoric disorder, and this is a very much more severe variant of PMS. Causes problems with work or personal relationships. Have marked irritability, dysphoria, mood lability, anxiety, fatigue, a sense of feeling overwhelmed. These symptoms are cyclic. They occur in the last 7 to 10 days of the menstrual cycle. Treatment is similar to that for PMS, plus may warrant counseling, medications, and alternative therapy such as hypnosis and acupuncture. Encouragement of regular exercise, improved nutrition, smoking cessation, and oil of evening primrose, which is something you can buy in the natural food section, or even the natural herb section, in health and beauty, has been shown to help these women. And once doing that, in about 1 to 2 months, they might actually see an improvement of their symptoms. That would be the goal. Again, if you've never experienced PMDD, you have no idea how to. You can only empathize. You're unable to sympathize. But let me tell you, it can be really serious. I I try not to share too much in these, but I do like to share that PMDD is so serious that I think women do things, and I know this out of experience. They do things, they think things, they say things that they normally would not do, say, or think. And so we need to be sympathetic to what is going on with them. Endometriosis is another problem that women may experience. This is the presence or growth of endometrial tissue outside of the uterus. It does cause major problems and major symptoms. The dysmenorrhea. They also have pain during intercourse, very heavy menstrual bleeding. Diagnostically, we're going to do a pelvic exam, transvaginal ultrasound, and pelvic laparoscopy. Endometrial tissue contains glands and stoma that respond to the cyclic hormonal stimulation. So whenever it's stimulated and uh, if it has grown outside of the uterus, which it does usually. I know women that has grown outside of the uterus and it's grown in their lungs. So every month when they bleed, that endometrial tissue bleeds there as well. As the lesions build up, they bleed and slough off during the menstrual cycles. They cause a lot of pelvic pain. They cause pressure and inflammation to the adjacent organs. A lot of times when women go in to finally have a hysterectomy or go in to have a laparoscopy to remove some of the tissue, they'll find it's grown on their ovaries. It's on the fallopian tubes. It can be on their GI tract. It can be on their bladder. It can be on the abdominal wall, and again, like I said, it can be on the lungs. This inflammatory response causes these adhesions to form. Most often, it's diagnosed in a woman's 30s and 40s. Endometriosis may worsen with the repeated cycles, or it may remain asymptomatic and underdiagnosed, even eventually disappearing after menopause. Sometimes the severity of it can go away, and I know of women also, and that once they've had children, it has gone away. Severity of symptoms do change over time. That it may not reflect the extent of the disease, and that's oftentimes why we have to go in and do a laparoscopy. Pain often lasts longer than normal menstrual cramps, may get worse as the period continues, and may not go away until after it ends. Patients may also experience painful intercourse and suffer from infertility due to it. I just have some common sites here for sites of endometriosis. Tissue may be planted, like I said, on the ovaries, uterine ligaments, vaginal septum, sigmoid colon, pelvic peritoneum, cervix, inguinal area. The overall incidence is 5 to 15% of women in their reproductive ages. It's seen in 40% of women with infertility. Inflammation may damage sperm or egg or interfere with movement through the fallopian tubes and the uterus. Severe cases, the fallopian tubes may be blocked by adhesions or scar tissue. Okay, so management, we want medications to control the pain. Probably going to end up on some hormone drug therapy, GnRH agonist, androgen derivatives. Surgical interventions, we're going to do laser therapy, removal of the endometrial tissue, but they do have a 40 to 80% chance of it reoccurring, and the only true way to get rid of it is with a hysterectomy. And then treatment also depends on the following factors: age and desire to have children, the severity of the symptoms and the disease. Suppression of the endogenous estrogen production and subsequent endometrial lesion growth is the cornerstone for managing the disease. So that's why we're going to do GnRH, a gonadotropin releasing hormone, and that would be a Lupron. That's one that we would probably give. It acts by suppressing the pituitary gonadotropin secretion. It kind of medically induces menopause, which results in side effects of hot flashes and vaginal dryness. So a very young woman is really going to be very resistant to doing this. Usually limited to 6 months because it can lead to some bone density loss. It may be extended up to 1 year in some cases. If we do a synthetic androgen steroid, danazol, this results in decreased estrogen and regression of the endometrial tissue. Side effects, though, include masculinizing traits, which may be hard for women to accept. Hot flashes, headache, fatigue, and depression. Ovulation may not be suppressed, so contraceptives should be used, because if not, it can cause a female fetus to have pseudo-hermaphrodite symptoms. Women usually do not tolerate these side effects very well, so they may not really want to start this drug. Oral contraceptives continuously for 6 to 9 months. just to stop periods. So that means they're not going to have a week there where they're just going to take the little sugar pill. We're going to have them go and take it and not have one. It kind of puts the patient in a pregnancy-like state. It does relieve the symptoms, but doesn't prevent scarring or reverse the physical changes. The only definite cure, though, is a total hysterectomy, like I just said, with the removal of the ovaries. If you do not wish to have both the ovaries removed at the same time as a hysterectomy, um, you don't have to. It's going to have to depend on the extent of what's going on in there. If you have the endometrial tissue that has implanted on the ovaries, then likely you're going to have them removed. So a lot of young women who opt to have a hysterectomy may not, they may not want to have those taken out because they may not want to start hormone replacement therapy. So there's a lot of factors involved. So alterations in cyclic bleeding, oligomenorrhea, is infrequent periods. Their intervals are equal to or greater than 40 to 45 days. Hypomenorrhea is a scant amount with normal intervals, so they just don't have a lot of bleeding. Menorrhagia is irregular or intermenstrual bleeding. Menorrhagia, excessive menstrual bleeding, and that can be a single episode of heavy bleeding that may indicate a miscarriage, or another very common cause for it would be uterine fibroids, like lymiomas. Now, the oligomenorrhea and the hypo is usually caused by something hypothalamic, pituitary, or an ovarian dysfunction. We want to treat the underlying cause. It can also be not an unwelcome, but a welcome side effect of oral contraceptives. Menorrhagia usually refers to an episode of bleeding, like I said, or they may have that intermenstrual, that breakthrough bleeding that can be caused by oral contraceptives or an IUD, and that's kind of common within the first 3 months of therapy. You want to make sure that you're taking the pill at the same time each day. That might correct the problem. If spotting continues, then there's a good chance that there needs to be some different formulas that are used. Menorrhagia, that's the excessive menstrual bleeding in either duration or amount. So other causes for it would be endometrial polyps, hormonal disturbances, benign and malignant neoplasms, infection, and contraception, usually from IUDs. May have a single episode of heavy bleeding or may have regular flooding, so they have to change their tampons or pads every few hours for several days. We might have to look at a hemoglobin and hematocrit to assess for anemia, and an HCG to rule out if there was a pregnancy loss. Okay, so uterine fibroids are lyomas or myomas. These are benign growths that develop in the muscle tissue of the uterus. Signs and symptoms that a woman might see: changes in their menstruation, the length, the frequency, the amount, pain during menstruation or intercourse, difficulty with urinating or frequent constipation, anemia, frequent miscarriages, and infertility. Now, the size and shape and location of fibroids do vary quite extensively. Usually they begin as benign, and they're estrogen dependent uterine tumors is what they are, and women can have multiple of them in the uterus. Diagnosis can be made with a pelvic exam, ultrasound, hysteroscopy, and a laparoscopy. The treatment is really going to be aimed at reducing the symptoms, shrinking the fibroid, and reducing its blood supply. If a woman wishes to maintain her childbearing potential, then a myomectomy may be necessary, and that is just the surgical removal of the fibroids. Oral contraceptive pills in a low-dose form control the heavy bleeding and help to reduce the painful periods. Progestin releasing an IUD can also be inserted. This helps to reduce the heavy bleeding as well. Eventually, a woman may need an endometrial ablation, which destroys the lining of the uterus, and it's indicated for fibroids that are greater than 3 centimeters. And they'll do MRI guided ultrasound surgery as well and use ultrasound waves to destroy the fibroids. So there's a lot of different things that we can do to try to help preserve the ability for women to conceive. However, if it's looking like it's not going to, if infertility persists, the fibroids persist, and having so many frequent bouts of anemia or staying chronically anemic, there's just so many different aspects to look at there. Then a hysterectomy is probably going to be the only way that a woman with uterine fibroids will have a little bit of peace and comfort in her body. Abnormal dysfunction uterine bleeding. Um, it's any form of uterine bleeding that is irregular in amount, uh, duration, or timing, and is not related to regular menstrual bleeding. It's also called dysfunctional uterine bleeding. AUB it's it's not it doesn't occur with the menstrual cycle. It usually occurs at opposite ends of the reproductive lifespan, so the very young or the very old. Diagnosis is usually made only after they rule out all other causes. Frequently associated with ovulatory cycles, which occur during the first year after a woman begins a period or during that perimenopause phase. And ovulation occurs because estrogen rises in early phases of the menstrual cycle. And then the absence of ovulation, the corpus luteum doesn't form, and the progesterone is not produced. So then what happens is the endometrium becomes hyperproliferative, and it leads to irregular sloughing. So it's a kind of what it does is it builds up that great cushion, um, and then it has this irregular times where it's just sloughing off like it does with the menstrual period, and so the endometrium is sloughing off, and they have excessive amounts of bleeding. The management for it, estrogens, it'll help with the vasospasm of the uterine arteries to decrease the bleeding. Progestins stabilize the endometrium. Oral contraceptives regulate the cycle and suppress the endometrium. An IUD will suppress endometrial growth. The iron supplements may be needed because these women are going to be prone to chronic anemia. So we want to replace those iron stores that's lost during the bleeding. And eventually she might end up needing a DNC, endometrial ablation, or even a hysterectomy to control the symptoms of this. Okay, so endometrial hyperplasia. This is overgrowth of the endometrium due to excessive amounts of estrogen. Typically occurs after menopause or during perimenopause. If you're a woman over the age of 35, early menarche, late menopause, nulliparity, diabetic, a woman with polycystic ovarian syndrome, obesity, or smoking, then these have been identified as risk factors for developing it. The signs and symptoms typically going to be heavy bleeding cycles, and they're usually less than 21 days, and then bleeding after menopause. So in a normal cycle, the first part, the estrogen increases. It causes the lining to grow, thicken to prep for the pregnancy, gets all cushiony in there. After ovulation, progesterone increases to prep the endometrium to receive and nourish a fertilized egg. And then if the pregnancy doesn't occur, estrogen and progesterone decrease. So the decreased progesterone triggers the shedding of the lining. Hyperplasia, though, is caused by excessive estrogen without the progesterone. So if ovulation doesn't occur, then progesterone is not made and the lining then is not shed. So endometrium then will continue to grow in response to that estrogen. So it's like a big old pillow in there. After menopause, though, ovulation stops and then the progesterone is no longer made, so that's why we get this big buildup of that endometrial hyperplasia. Diagnosis is going to be done through transvaginal ultrasound, biopsy, because we also need to rule out cancer. Management, progestin rather, we're going to have to give that PO, IM, or an IUD. Hysterectomy is likely going to be a better option. Prevention, hormone replacement therapy with estrogen and progestin, oral contraceptive pills with both, and then weight loss. Let's talk a little bit about polycystic ovarian syndrome. It is associated with some high insulin resistance and increased androgens. Signs and symptoms that women are looking for with it: irregular periods, absent, heavy, or unpredictable periods, infertility, obesity, excessive hair growth on their face, chest, abdomen, or upper thighs, hirsutism, acne, oily skin, patches of thickened, darkened skin, and multiple small cysts on their ovaries. So they get high levels of insulin that then leads to these imbalances in other hormones. High levels of androgens inhibit ovulation, and then this causes the acne and excessive hair growth. These women do have quite a bit of health risk when they're diagnosed with PCOS, cardiovascular disease, metabolic syndrome, type 2 diabetes, and endometrial hyperplasia, as well as endometrial cancer. Here's just some pictures of what you might see on diagnosing a patient. And you get pictures up here because, guys, you need to know what pictures and what you might assess with a patient who you suspect has PCOS symptoms. Now, are you going to be seeing their ovaries? Absolutely not. But you're going to be seeing this on this neck here, that dark pigmented skin. You see the excessive hair growth as well. How are we going to manage it? We're going to manage it with oral contraceptive pills because we want to regulate their cycle. We want to decrease their androgen levels and reduce the hirsutism and acne that they're experiencing. We'll have to give them insulin sensitizing drugs because we need the body to help it respond to insulin, decrease their androgen levels, and improve ovulation. Weight loss, because this will also help improve insulin levels. Spironolactone or aldactone, and finasteride that will help with the propecia. Alright, so we're going to talk about sexually transmitted infections. These are infections of the reproductive tract that can occur throughout a woman's life. It does cause some significant reproductive morbidity, maternal infections, infertility, and there's also the emotional costs that go along with it. Primary prevention is the most effective way of reducing adverse consequences of STIs for women. It does cause maternal infections that can pass to the embryo or fetus. It can cause infertility in the woman and carries a high emotional cost. In order to have prevention, we have to assess and we have to educate. In your textbook, there is some common questions that we should be asking our women when we're doing intake assessments and trying to obtain information on them. You need to be asking those questions about if you're sexually active, do you use protection? And there you can look at that box that is on page 72 of your textbook, box 4.3. So some of our sexually transmitted infections: chlamydia, gonorrhea, syphilis, pelvic inflammatory disease. We want to assess the 5 Ps. They should be asked. We should determine a woman's risk of developing STIs. We need to know partners, practices, prevention of pregnancy, protection for STIs, and past history of STIs. I have listed, for time's sake, all the infections and viruses as well as vaginal infections on the next few slides. I'll not be going into depth into each one of these, but it is a student responsibility to review these infections, viruses, and vaginal disorders. Some more sexually transmitted viral infections: human papillomavirus, genital herpes, HSV1 or HSV2, hepatitis A, B, and C, HIV, and Zika virus. Vaginal infections: bacterial vaginosis, candidiasis, trichomonas, and group B strep. We're going to talk about group B strep throughout this semester. That's something we assess on women when they're getting ready to deliver. If their vaginal cavity or canal carries the infection, the group B strep, then these women are going to need to be treated pre-delivery. So we'll talk about group B throughout this semester. Benign problems of the breast: fibrocystic changes, 50% of women will have a breast problem at some point in their adult life. Most common sign of a breast problem is a palpable mass. Fibrocystic changes, those are the most common, absolute most common benign breast problem. That was a mouthful. Not a disease, but a condition found in healthy women's breast. Pain and tenderness can fluctuate with the menstrual cycle and become worse with menopause. Usually the etiology for it is an imbalance of estrogen and progesterone. They'll have increased estrogen and decreased progesterone. Risk factors for it: nulliparity, low parity, late menopause, estrogen therapy. Sometimes a woman may form cyst as well. Their breasts are going to feel dull. They're going to have heavy pain, fullness, and tenderness. Usually develops 1 week prior to a period and subsides 1 week afterwards. We're going to look at diagnostically doing an ultrasound, mammogram, and biopsy. We want to encourage them to limit their salt intake. We may even start diuretics. Avoid caffeine, alcohol, and smoking, because those can cause increased pain. Wear a supportive bra. Use heat and ibuprofen. Only about 5% of fibrocystic conditions have changes that are indicator for risk for breast cancer. And again, we're going to do a workup that's going to include that ultrasound and that mammogram. This is fibrous tissue that's noted on a mammogram. And guys, it's also a little bit scary for women when they receive that in the mail and they hear you need to come back for a follow-up, just because we saw changes within the mammogram. And so they'll have women come back in and they'll have them do a mammogram again. They might even have diagnostic where they're doing x-rays and ultrasounds and checking everything to make sure there's nothing there that they're missing. Fibroadenomas are the second most common problem. These are masses that are solid, encapsulated, they're non-tender, and they're most often found in the upper outer quadrant. We're going to do a diagnosis that is made when we do a history and physical. A mammogram, ultrasound, or MRI is used. We might do a fine needle aspiration or surgical excision to find out exactly what we have going on. A lipoma is going to be a fatty tumor on the chest wall. Usually occur after the age of 45, and what they're going to find is they have this soft, palpable, and movable mass that's non-tender. There's really not any management that's going to be done for this unless a woman desires to have surgical removal. Again, this is just a picture that just kind of give you a visual of what you're seeing there is that fibroadenoma. So nipple discharge is also a benign problem. It's fairly common, but it should be evaluated carefully just in case there's something else going on. Sometimes women will experience bilateral serous discharge during nipple stimulation, and that's considered normal. It can be the result of an endocrine disorder, or it can be a malignancy. Galactorrhea, increased prolactin may occur as a result of a thyroid disorder, pituitary tumor, or chest wall surgery or trauma. And they're going to end up experiencing bilateral, spontaneous, milky, sticky discharge, result of a pregnancy or those increased prolactin levels. We're going to have to draw that prolactin level, and that usually has to be done between 8 a.m. and 10 a.m. And that's because, just FYI, prolactin is produced in mass quantities in our bodies at night. That is why women who are breastfeeding don't need to skip feedings during the night with their little ones, because the prolactin helps to produce the milk. So we don't want to draw that prolactin level though after they've had a breast exam, sex, or exercise. Mammary duct dystocia is inflammation of the ducts behind the nipple. It occurs in perimenopausal women. It's very self-limiting. They might have thick, sticky white, brown, or green discharge. They have burning, itching, maybe a possible mass behind the nipple that can be palpated. Diagnostically, we're going to look at mammogram and doing a culture on that discharge. Management is going to be antibiotics and excision. We're going to get that mass out of there. Intraductal papilloma is a non-palpable mass that develops in the terminal nipple ducts. It is usually unilateral. Spontaneous serosanguinous or bloody discharge will be noted. Management, we're just going to rule out a malignancy and we're going to excise that. It is rare, but it is a benign condition, so just know that it is rare. Care management for these patients, assessment of the breast, nursing actions. We want to make sure that they know how to do they know how to do breast self-exams. Do they know the correct technique and when to do so? We need to ask those questions. We need to be able to provide education, pain management, and pain management in this day and time is going to include Tylenol or ibuprofen because we have an opioid crisis. Is there a relation to the pain that goes along to the menstrual cycle? We want to assess dietary habits, their smoking, their stress level, and look at their fears as well. So breast cancer results from unregulated cell growth. The U.S. has one of the highest rates of breast cancer in the world. 1 in 8 will develop breast cancer. The growth rate is going to be dependent on hormonal influence, and it's going to be dependent on estrogen and progesterone. Begins in the epithelial cells lining the mammary ducts. There is a higher incidence in Caucasians, but mortality rate is higher in African Americans because it's usually found at a later stage. The exact cause of breast cancer is really not known. Risk factors do help us to identify that less than 30% of women in known breast cancer, let me just repeat that. Risk factors help to identify less than 30% of women in who breast cancer will develop. Women are the ones who actually detect 90% though of all their breast lumps. Non-invasive breast cancer would be in situ. This has not extended beyond the duct and lobule or the point of origin. Invasive or infiltrating is extended into the surrounding breast tissue with potential to metastasize. Most common is invasive ductal carcinoma. That invades locally the chest wall and the axillary lymph nodes, metastasizes to the bone, lungs, lymph nodes, liver, and the brain. Screening mammogram versus a diagnostic mammogram. It picks up a lesion of 0.5 centimeters and a palpable lesion usually at 2.5 centimeters on average. An MRI is very highly accurate, so there is a greater than 90% sensitivity to it. That means that they're going to discover more. If we did more MRIs, we would discover more breast cancers if that was the case. But it is very, very expensive, so that's going to be one of those drawbacks. Biopsy, we're going to look at the lesion. We're going to take a biopsy of the lymph nodes. More nodes involved, that means there's more aggressive cancer that's there. And so consequently, they're going to need more powerful chemotherapy. If we do a sentinel node biopsy, likely it's the first stop for spreading the cancer cells. We inject that harmless dye as a weak radioactive solution near the tumor. And that sentinel node, you think of sentinel node as, the sentry that goes ahead in the army to fight the battle. So that sentry node, that sentinel node is removed and tested for cancer cells. Hormone receptor status, we'll look at the estrogen and progesterone are both receptors. And we'll do DNA ploidy status. And we will assess the amount of DNA in the cancer cells to determine how aggressive that cancer actually is. So 50% of malignant breast cancers, breast lesions occur in the upper outer quadrant. You've got a little visual up there. I can't point to it, and I don't even think my pointer goes up here. But you can see exactly where 50% of them are located. And no staging rarely. It's non-invasive. It's ductal carcinoma in situ. Stage 1, then you're looking at a less than 2 centimeter growth, and there's no nodes involved. Stage 2, greater than 5 centimeters and no nodes, or 5 centimeters and the spread to the nodes. Stage 3, any size, and then it spread to the nodes or surrounding tissues. And stage 4, usually metastasized to the lungs, liver, bones, or the brain. So what about the risk factors? Risk just increases with age. It's associated with high estrogen years. Risk factors, family history. Is there a mother, a sister, an aunt, a grandmother? Is there a previous history of ovarian, endometrial, colon, or thyroid cancer? Not breastfeeding, and not when you decide not to breastfeed, or a woman decides not to breastfeed, it doesn't then reduce the number of menstrual cycles that you have, because then you'll start a menstrual cycle up within 6 weeks after giving birth. Typically, women who breastfeed will not start, if they're exclusively breastfeeding, will not have a cycle again for at least 6 months. Alcohol also increases estrogen levels. Obesity and the lack of exercise, and then what happens is the fat stores that estrogen. And so, you're looking at some modifiable and non-modifiable things. Early menarche, you can't modify that. There's nothing that you can do. Nulliparity or first pregnancy after 30. You might can modify that, but that's really independent of the woman, if she chooses not to have a pregnancy. Hormone replacement therapy, again, that can be modifiable or non-modifiable. It's sometimes it's a matter of quality. If you are having HRT, it's to keep your emotions in check, and the hot flashes back, and everything that goes along with it. Then for you, that might be a non-modifiable thing. We also look at BRCA1 and BRCA2 genes on patients. We're going to do treatment with radiation therapy to the breast and the chest. We want to get a history of their benign breast disease or increased breast density. We wanted to see if they can modify their obesity and sedentary lifestyle and stop drinking alcohol. So with the BRCA1 or BRCA2 gene, abnormal genes account for about 10% of breast cancers. The pros, look, I have Angelina Jolie on here. She may or may not be your favorite actress, for one reason or the other, but she did brought breast cancer and mastectomies to the forefront for many Americans. If a positive risk of breast cancer, then they have a 40 to 80% of developing it, so 3 to 7 times higher than the general population. Risk of ovarian cancer for these women, 16 to 60%, or about 2% of the general population. We need to evaluate these patients if there's a family history of someone carrying the gene, especially one of the women in the family. If there's a family history plus cancer, then but they're negative for the gene, then it could be another gene causing the cancer that hasn't been identified yet. So there's a lot of factors that go into breast cancer. Many test centers require genetic counseling before and after the testing. The pros, they can participate in research. The cons, if positive, they could face some discrimination for getting insurance and employment. The cost is also a con. It ranges from $300 to $3,000 depending on how comprehensive the screening is. Insurance may or may not cover the cost of that screening as well. They can get those results usually in 4 weeks, so the emotional cost may be high as well, waiting for that to come back. It's not recommended to test children that are less than 18 because there's no safe, effective therapies that currently exist to help prevent breast cancer in children that are quite young. The clinical manifestations that a woman might see, these are things that you can teach your patient. If you find you have a non-tender lump or thickening in the breast, if you're having unilateral discharge, nipple discharge, dimpling of the skin, change in skin color or texture, swelling or asymmetry, and if they start to notice that their nipple is retracting. 90%, like I said, of breast lumps are detected by women. Only 20 to 25% are actually malignant. That's still a lot, though. The lumps that usually are found are not painful or tender. And so, you might have women who just don't think anything about it. Oh, it's just nothing. Rule of thumb, any unilateral breast changes, mass, discharge, pain, or itching is not a good sign, and a woman should be evaluated. This is locally advanced breast cancer. I have seen breast cancer like this one time in my career. The breast that, as you're looking at your screen that's on the left, that is a retracted nipple. You can actually see the tumor itself, and you see the modeling on the skin. I had a patient that she didn't believe in receiving care. So she let it go and let it go until it went like this. And I'm all about trusting in the Lord to heal you, but I also trust in physicians that the Lord gave them the brains to try to work with me and help me out. But to each his own, her own, and for her, this was a fatal case of breast cancer. So the surgical management, we're going to do a lumpectomy. It's a conservative treatment without major cosmetic deformity. It involves the removal of the breast tumor, a small amount of the surrounding tissue, and then they'll take a sampling of the axillary lymph nodes. Partial mastectomy is going to be removal of that segment or quadrant where the breast cancer is. There's also the total or simple mastectomy. They're going to take the removal of all breast tissue, the axillary nodes, and the pectoral muscles are also removed. A modified radical mastectomy, they're going to have patient's going to have removal of the entire breast, axillary lymph nodes, and sparing the pectoral muscle if possible. A radical one is removal of all breast tissue, axillary nodes, and then the pec muscles as well. Breast reconstruction is usually begun at the time of these surgical interventions. It's really going to depend, though, if they can. It's going to depend on the extent at which of their cancer. But if we can, then it will be started. We have been known to do a flap reconstruction, and I think I'll have something on the next page that shows that flap reconstruction. And we'll put expanders under the chest wall to do tissue expanders so that eventually that area can hold a breast implant for a patient. And again, it's going to depend on the extent of the cancer. Okay, so here's the different flaps that we have available, and I wish I could point to you. Okay, so in the top corner, we're going to this is going to be a flap that comes around from the back, and they bring that flap around to the front, and a lot of times they'll put the tissue expanders underneath there. Well, you have to take care of those women. You have to put nitroglycerin on the incisions. We got to keep the blood flow going to it. We don't want it to die. Then we have an abdominal flap that we use also to, and I don't know that we use those as much anymore as we use the flap that comes from that back right there, that area. So we have medical management, not just surgical management, that we have to go through for these women. We're going to do radiation. It usually follows surgery most of the time, in addition to the chemo. The patient's going to experience some side effects, swelling and heaviness in the breast, maybe feel like a sunburn. Changes to the tissue does resolve in 6 to 12 months. It can cause lymphedema. So they do need some close follow-up. Women should be advised not to wear snug sleeves. Tight clothing should be avoided, as well as tight jewelry. Anything that will decrease circulation in that affected arm does not need to happen. They don't need to lift anything more than 10 pounds or reach above their head. We'll also look at doing some hormonal therapy. We'll check to see if the cells have hormonal receptors. Then if they're present, the cancer can be influenced by estrogen and progesterone or both. Tamoxifen is an oral anti-estrogen medication that typically we give to our breast cancer patients. But it does come with some side effects like hot flashes, um, nausea, vomiting, fluid retention, weight gain, thrombocytopenia, and it does increase the risk of endometrial cancers and DVT. Chemotherapy, we want to totally eradicate that if we can, or impede the growth of the micrometastatic disease. It significantly reduces the risk for reoccurrence and mortality in patients with node-positive disease. Usually given in combo with several drugs, and we're going to do it maybe 1 to 2 times a month. But the side effects, leukopenia, neutropenia, thrombocytopenia, anemia, gastrointestinal side effects, and partial or full hair loss, along with the nausea and vomiting. Premenopausal women must also deal with symptoms of being thrown into menopause, and then also dealing with infertility once they start chemotherapy. Probably need to discuss reserving those eggs for when she comes off of chemo. If she's able to carry a pregnancy, then at least she would have her eggs preserved so they can be implanted. We also want to look at tumor markers after the therapy gets started to determine the effectiveness of their therapy. Again, here's some tamoxifen information. Sorry, I've got it on 2 ones. It does interfere with the action of estrogen on cancer cells. Again, menopause-like symptoms, complications, uterine cancer, blood clots, stroke, cataracts. Evista is another one. It prevents osteoporosis in postmenopausal women. It does have a protective effect against breast cancer. Side effects, again, menopause-like symptoms, joint pain, and leg cramps. And then again, they have a complication of developing blood clots. So it does have quite a couple of benefits that go along with it. So those are just a couple of drugs that we might administer to our breast patients. But we have to also know how to take care of our patients after a mastectomy, because this is women's health. We're going to need to do pain management. I'll be honest with you though, taking care of mastectomy patients, they really did not have a whole lot of pain. There was not very many of them that experienced pain. Typically the pain could be controlled with making minor adjustments to them in the bed. Elevating both of their arms and taking the pressure off of their chest wall. So pain management doesn't necessarily mean that we're going to be giving pills. It can be what we do to support them and help them to get a comfort level. We want to look at their drains. We have to monitor the output. We want to look at the color. We want to look at the amount. We want to make sure that we provide emotional support. And then there's referral for wigs and prostheses that are going to come along. Prostheses usually are fitted only though about 6 weeks after surgery, so we're taking care of a woman post-operatively. We might not be, and now some of us might, we might be in a clinic where we're working that we're dealing with patients after surgery 6 weeks after. This is when we would suggest that they get fitted for a prosthesis. Because once their wounds start to heal, then and the post-op edema has resolved, then we can start doing that fitting. And there are prostheses that go in within the bras. A lymphedema occurs in about 10 to 30% of women. It is a complication. It occurs because we've removed the axillary lymph nodes. They get transient edema in a post-op period that occurs until the collateral circulation has developed. Again, we want to avoid tight-fitting clothing, tight-fitting jewelry. We want to make sure that they are not shaving their underarms with a razor, a straight razor. Think about anything that can cause don't garden without gloves on. I know it sounds crazy, but you might get a cut that infection is going to enter that system. Hematomas can develop about 12 hours after surgery. So you might see some swelling, tightness, pain and bruising, increased bloody output in the drain. We might do a compression wrap or have to go back to the OR to stop the bleeding, just depends. Pain management, warm compress and warm showers. It usually resolves in 4 to 5 weeks. A seroma is a collection of serous fluid in a cavity. They're going to have some swelling, heaviness, discomfort, sloshing of fluid. They may develop temporarily. This may develop temporarily after their drain is removed, or if the drain becomes obstructive. We want to unclog the drain and aspirate the fluid if this occurs. Again, more patient teaching. There's some arm exercises they can do. Sleep on their back or their non-surgical side. Carry their luggage or purse on a non-surgical side. Elevate the arm above the level of the heart. Avoid blood pressure, IV, and blood draws on that side. Avoid lifting greater than 30 pounds. Avoid wearing tight elastic clothing or jewelry. Perform those arm exercises. Wear sunscreen because we don't need it to get infected with a sunburn. Wear insect repellent because we don't want bug bites to be scratched. Wear gloves for gardening. Oven mitt to remove objects from the oven. An electric razor for shaving. We want to also avoid cutting the cuticles. And here's just some arm exercises. I'm not going to go through those, but there are arm exercises that can be done for women following a mastectomy. And we're going to talk about some cervical cancer, most commonly caused by HPV, the risk factors, and they develop slowly over time as well. Greater than 7 full-term pregnancies, multiple sex partners, sexual intercourse at an early age, smoking, and oral contraceptives. Signs and symptoms, they're going to have vaginal bleeding, unusual vaginal discharge, pelvic pain, and pain during sexual intercourse. Before cancer appears in the cervix, they're going to have some abnormal cells, dysplasia that appear. More abnormal cells are present, and they're less likely they are to go away at that point. Dysplasia is not treated, and some people just don't treat it. It may turn into the cancer over time. Not all women with HPV will develop cervical cancer. Just know that. Women who do not regularly have a pap smear to detect HPV or abnormal cells in the cervix are going to be at a greater risk of cervical cancer. It's going to be diagnosed with pap smear and biopsy. Treatment's going to depend on the stage and desire to have children and the patient's age. We might do a LEEP procedure, a loop electrosurgical excision procedure. This takes an electrical current that passes through a thin wire loop that acts as a knife to remove that abnormal tissue or cancer. We can also do cryosurgery, freeze and destroy abnormal tissues, such as when they have carcinoma in situ. It's also called cryotherapy, so cryotherapy or cryosurgery. Radiation, this can be external or internal that they do that. There are over 12,000 estimated new cases every year, and over 4,000 deaths from it. Risk factors, well, let me first say that malignant cancer cells form in the tissues of the endometrium is what ends up happening. It is the most common invasive cancer of the female reproductive system. Endometrial cancer is. It's diagnosed most often in a postmenopausal woman. Average age is 60. Remember tamoxifen that I talked about? It acts like an estrogen on some tissues in the body, such as the uterus, but it blocks the effects of estrogen on other tissues, such as the breast. So it's used to prevent breast cancer in high-risk women. However, taking it for more than 2 years increases the risk of endometrial cancer developing. The risk is greater in the postmenopausal woman. Endometrial cancer, though, is usually found a whole lot earlier than what cervical cancer is, because it usually causes symptoms such as vaginal bleeding. There's not a standard or routine screening, though, for endometrial cancer. So with endometrial cancer, a combo hormone replacement therapy or contraceptive with progesterone might be beneficial for this woman. Physical activity, because we want to get everybody's weight down. Pregnancy and breastfeeding, because that's when estrogen levels are lowered. Diagnosis is going to be made with a pap smear or a transvaginal ultrasound and a biopsy. Ovarian cancer. Ovarian epithelial cancer is cancer that occurs over the covering of the ovary. There's also the ovarian germ cell tumor. There is no standard or routine screening for ovarian cancer, though. Screening has not been proven to decrease this death rate. It's quite extensive. Diagnosis is made with pelvic exam, ultrasound, and them doing a CA-125 tumor marker blood test. Family history of breast, ovarian, colon, or endometrial cancer. Inherited gene mutation, the BRCA1 or BRCA2, estrogen-only hormone replacement therapy, fertility drugs, and endometriosis are all risk factors for it. Signs and symptoms: abdominal pain or swelling, pelvic pain, GI problems, gas, bloating, or constipation, maybe a feeling of fullness. Management: hysterectomy, radiation, chemo, monoclonal antibodies, prophylactic oophorectomy. We're going to take those ovaries out. Oral contraceptives, the longer taken, the lower risk. It may last up to 25 years after stopping their use. Pregnancy and breastfeeding, because again, ovulation has stopped. Bilateral tubal ligation or a hysterectomy also. There are over 22,000 new cases and 14,000 deaths estimated. So it's quite a lot. If we do a monoclonal antibody therapy, this is a type of targeted therapy that uses antibodies made in a lab and form a single type of immune system cell. They can identify substances on cancer cells or normal substances that may help cancer cells grow. So then they go and attach to it and kill the cancer cells, so block their growth. Pretty cool when you think about it. Or they eventually just keep them from spreading. It's given by infusion and may be used alone or to carry drugs, toxins, or radioactive material directly to those cancer cells. Vaginal and vulvar cancer, it's probably one of the worst cancers that you can take care of in a patient. Just in my opinion, in women's health, okay? Maybe not the worst, but in women's health, it's one thing to have your breast removed. But it's another thing for a doctor to have to go in and to remove your vulva. It's probably some things that I have in my nurse brain that I can never get out seeing it. Signs and symptoms: you're going to have vaginal discharge or bleeding, pelvic pain, especially during sex or urination, itching, burning, skin changes, lumps, ulcers. How are we going to take care of it? Surgery, laser, excision, vaginectomy, hysterectomy, and pelvic extension. Y'all, it's really terrible to see. I can't even describe it to you. Risk factors: women over 60, exposure to DES in utero, and that was a drug in the 1950s that was used to prevent miscarriage. HPV, genital warts, abnormal pap smears, and then other GYN cancers. Diagnosis is going to be made with a pelvic exam and a biopsy. The pelvic extension is going to be, they're going to take the lower colon, rectum, bladder, cervix, vagina, ovaries, and lymph nodes, and then a stoma is created for urine and stool. Probably one of the, I'm going to tell y'all a funny story. I try not to tell too many stories because I know you get half of y'all that like them and half of y'all that don't. But I just bring things into focus. So I was taking care of a patient one time, and she was one of those smokers, had that really raspy cough and that raspy voice. She was a hoot to take care of. She was one of the best patients in spite of everything that she was going through. And so physician had removed the vulva, so there's nothing there. There's no mons pubis. There wasn't a labia minora, majora. It was just this this cavern. And he wanted us to take the catheter out really soon on this poor woman. And so all day long they tried getting a catheter back in there, and they didn't want to call him because he just wasn't the nicest of physicians. So I came in that night, and they were like, Lena, you gotta go try. So I literally, y'all, went in the room, and I had been taking care of her, so I knew what she looked like. And I mean, you got sutures all around, and it's just a cavern, and she has to be mortified, and she's miserable because she had to pee, and she couldn't. I mean, you didn't have a problem finding a urethra. There's no doubt. But I went in, and I just remember just closing my eyes as I started to insert the catheter and just praying that the Lord would just lead this catheter where it needed to be. And I mean, thankfully he came through because we got urine. And so I was pretty new to nursing at that point in time. And it was right after Krispy Kreme donuts opened. And so she had been trying to get up and set up. And she said, "Hey, Elena, y'all got any of those donuts?" Well, y'all, I had stacks of donuts down in the nurse's station, Krispy Kremes, because patient family members were bringing them left and right. I probably put on 30 pounds that year. And so I said, I looked at her as innocent as I possibly could look at her, and I said, "Krispy Kreme?" And I just said she had that raspy cough and that raspy voice. She started laughing with that raspy sound and coughing and laughing and coughing. She was talking about the donut that she sat on. Anyway, I just wanted to give y'all something to laugh about. I know this is a cancer that just bothers me so much. It bothers me to see, but it was nice that I had a great patient that I got to take care of with it. And I know she was mortified knowing that it was all gone, but just treating her like and doing that with the Krispy Kreme donuts, y'all literally made her night. She was just she told everybody who came in the room about it, even that morning when somebody came in to draw her blood. So just try to laugh with your patients and have fun with them because they're in situations that no one really wants to be in. So this is just a chart. I'm not going to read that for time's sake. We're at 2 hours on this lecture, and I will at some point see you in the classroom for testing. I hope you have enjoyed this lecture. Thank you for your time.